Yes.
Yes, sir. Yeah, good morning, sir.
Okay, good morning.
Good morning. Morning.
Surgery at IPGMR SK Hospital. We will moderate this session today. So, Snehashish, you present your case and we go for discussion beyond that. Share
Okay,
your
sir.
screen and present.
Okay, sir. Good morning, sir.
Yeah, good morning. Please start
Good morning.
presenting your case.
Yes, sir. So the patient is 11 months old male baby Rashid, residing in Murshidabad, presented to us with a visible gap in the upper lip and roof of the mouth in the right side since birth, with nasal regurgitation of milk from nose while breastfeeding and nasal intonation of voice. Shall I proceed, sir?
Yeah, these are the chief complaints, isn't it?
Yes, sir.
Yeah. Okay, proceed. Please proceed.
So this is a firstborn child of parents aged 28 years mother and 32 years father from a non-consanguineous marriage, presented with a history of split in the roof of the oral cavity on the right side since birth. There is history of difficulty in feeding as well as that of nasal regurgitation during feeding since birth. Nasal intonation noted in his speech. No history of any spells of bruised discoloration of lips. There is history of frequent episodes of cough and cold. Shall I move on next slide, sir?
Yes, please.
In the past history, there is no history of any comorbidities like hypertension, diabetes, or thyroid disorders, and no past history of any surgery. Antenatal history, age of the mother 28 years during the pregnancy. There is no history of any infection during pregnancy or gestational diabetes mellitus. History of intake of anti-epileptic drug, that is sodium valproate, present since past 10 years and also throughout the pregnancy. No history of alcohol intake or smoking, no history of consanguineous marriage, and no history of any abortion. Shall I proceed, sir?
Yes.
The natal history. The child was born at term by normal vaginal delivery in a district hospital and cried immediately after birth. The birth weight was 3.1 kg. No history of any spells of respiratory distress after birth or need for prone positioning. Shall I proceed, sir?
Yes,
Yeah,
what is
continue.
the yeah?
Yes, sir. So postnatal history, among which feeding history, exclusively breastfed up to 6 months of age and thereafter complementary feeding started by means of spoon and is now being continued. There is history of nasal regurgitation of food when not burped properly. Immunization status, the baby is immunized up to date as per national immunization schedule, sir.
Yeah, proceed.
Okay, sir. Family history, there is no history of similar or any kind of congenital anomalies in first degree relatives. And sir, history part is now complete. Sir, shall I move on to the examination?
Yeah.
Okay, sir. On general survey, the baby is alert, conscious, and cooperative. There is no cyanosis, jaundice. Pulse rate 104 beats per minute, and it is regular. Blood pressure 100 by 60 millimeter per mercury, and saturation was 98% in room air, and he was affable during examination. Anthropometric measurements are adequate for age. To ascertain this, we plotted the weight for age on a growth WHO growth chart for boys, and it well above the 50 percentile, and height for age is also uh, within the 50 percentile. So local examination.
Yeah.
Snehashi, she complete the presentation. Then Dr.
Oh,
Das will
okay,
keep on asking.
okay, sir. Okay, sir. So upper lip is split on right side, which is extending into the roof of the oral cavity. Dentition, there is discontinuity of upper set of dentition. There is mild protrusion of upper set of teeth as compared to the lower set of teeth. The child has 6 teeth in total, 2 upper central incisors, 2 lower central incisors, and 1 upper lateral incisor on the right side, which is displaced. However, the other lateral incisors on the upper side, on the left side, is in normal alignment. Palate complete cleft, which includes hard and soft palate on the right side, gap being 1 centimeter. Humor attached to the M side. There is no retrognathia or trunk protrusion. To summarize the case, the patient is a first-born male child of parents aged 28 years and 32 years from a consanguineous marriage, presented to us with a history of split in the upper lip and over the roof of the oral cavity on right side since birth. The mother also complained of nasal regurgitation of milk during breastfeeding since birth, and the baby is also having nasal intonation during speech. The bisyllables. The patient speaks bisyllables with nasal. Okay, sir. Patient's mother has a history of intake of anti-epileptic medication before and during the antenatal period. Otherwise, antenatal and natal period were unremarkable. After birth, child was detected with above mentioned defects. Apart from these, no other congenital anomalies were noted. On general examination, the child is conscious, alert, playful with normal vital parameters. Systemic examinations were also within normal limits. On local examination, upper lip, there is a split in the right side, which is extending into the roof of the oral cavity. There is discontinuity of the upper set of dentition. There is mild protrusion of the upper set of teeth as compared to the lower set of teeth. The child has 6 teeth in total, 2 upper central incisors, 2 lower central incisors, and 1 upper lateral incisor on the right side, which is displaced, and other lateral incisors on the left side is in normal alignment. On examination of palate, a gap approximately 1 centimeter is noted in the right side involving both hard and soft palate.
Yeah, thank you. Thank you, Dr. Subhashish. Can you go back to the single slide where there is a picture of that patient or the child? I think it was in the general examination, first or second slide,
Yes,
a local examination. Yeah. So, do you have any other view or do you have any other picture apart from this?
no, sir, it was hard to find out a picture, so I had just only one picture, sir. Sorry, sir.
You have taken this picture?
No, I have collected this picture from my other batchmates, sir.
Okay, so your diagnosis is right-sided, complete cleft of the lip, the alveolus, and the palate.
Yes, sir.
But from this picture, it is difficult to interpret whether it is a complete cleft of the lip.
Yes, sir. Yes, sir. The palatal view is missing.
No, that is okay. I don't want the palatal view. I just wanted to see the lip, the upper lip completely. Because if you give a diagnosis of a complete lip and alveolus,
yes, sir,
there should not be presence of any nasal sill or nasal floor. Okay.
Okay, sir. Okay,
So
sir.
in your picture, it is appearing that there is some part where there is a something appearing like a nasal floor or nasal sill.
Prolibium type. Yes, sir.
Yes, nasal sill.
Yes,
Anyways, so what is the age of the child? At
11
present?
months, sir. 11 months.
July born. Okay.
Yes, sir.
So what is your plan now? Let us go from plan towards the discussion.
Yes, sir.
What is your plan now?
Sir, the case of cleft lip and cleft palate is managed by a multidisciplinary team comprising of maxillofacial surgeon, general surgeon, pediatrician, uh, senior nurse specialist, and other
No, that is okay.
specialists.
Are you planning any operative
Yes, sir.
intervention now? And if you're planning, what is your plan of surgery or plan of treatment in this child?
Sir, in this case, the cleft lip should have been repaired at the age within the age of 3 to 4 months, sir, but it was not done. It is a delayed presentation. So cleft lip repair and soft palate repair must be my first priority, sir.
So you want
And this
to
patient, you talk about this patient.
Yes, sir.
This patient is 29 months. How are you going to proceed with this patient?
Yes, sir. For this patient, I would like to send some blood parameters to for general anesthesia and also chest X-ray PA view. And as there is a history of recurrent episodes of cough and cold, and I would also like to do echocardiography of this patient, and after which the surgeries can be planned, sir.
you are planning for a cleft lip repair along
Yes,
with
sir.
along with a soft palate repair.
Yes, sir.
Okay. So in this stage,
In this stage, yes, sir.
yeah, I will. Though it is not a very common practice, but I will agree with this plan. And what is the next operative plan if you are successful in doing a complete cleft correction, lip correction, and a soft palate correction? What is your next step?
Sir, after the soft palate is corrected, then after 6 months, then 3 to 6 months, sir, the hard palate can be corrected. Surgeries can be done, and after which the patient is followed up with speech therapy for proper speech development. And if required, at the age of 6 years to 8 years to 12 years, orthodontic surgery procedures can be done. And at a later stage, when the pubertal growth is complete, sir, if required, then orthodontic surgeries can also be done. So these are the surgical options, sir, for this patient at the different stages of his age.
So by doing a cleft lip repair and a soft palate repair together,
Yes.
what extra advantage will you get than doing a cleft lip repair now and a cleft palate repair later? What is your intent
Sir,
for such planning?
intent, sir. The goal of the surgery is correction of deformity of face, nose, and lips. First, second is correction of speech, feeding, and also dentition, sir. So, as the
You are repairing the posterior part of the
yes, sir.
velum or the palate. So
Yes, sir.
by
Sir, the
doing a
nasal,
posterior repair, what
yes, sir.
advantage, extra advantage, or what benefit you want to give the patient?
Yes, sir. Sir, if posterior soft palate is repaired, sir, the velopalatine closure uh, takes place. So the nasal intonation of voice can be corrected at this stage because the voice of the baby or the linguistic development of the baby is almost sir 11 months old for this case, and within 15 months or to 16 months of age.
What are the parameters of language development and normal parameters? Can you throw some light on this?
Yes, sir. Yes, sir. So the normal milestones for speech are like 3-letter word at the age of 3 months.
Since when
Yes.
since when does the meaningful voice or meaningful utterances words start?
Yes, sir. Sir, at the age of 6 to 12 months, sir, monosyllables the baby can speak monosyllables, and also within 9 to 12 months, bisyllables, the baby can speak, sir.
Yeah. So monosyllable at cooing sounds at 6 months.
6 months
3 months. Cooing sounds
is
at 3 months. Then
Mm.
monosyllables
6
at
months
6 months.
monosyllables, and then after 6 months to up to 12 months bisyllables.
Bisyllables
Or
and meaning sentences with 1 or 2 words at one
one
and
or
a half
two.
years.
Yes, sir. Yes, sir.
Sentences with
Sentence.
one or yeah. So
Yes, 18 months.
yeah. So what are the normal components of a speech? I mean, like in your case presentation, what are the problems you expect to develop in this child about speech?
So for phonation of certain
Why there is nasal intonation, and why there is nasal regurgitation?
Yes, sir. Yes, sir. So for phonation and for creation of complete suckling power, the velopalatine fold needs to be touched
It's
with
not
the posterior.
the terminology is velopharyngeal, not velopalatine.
Velopharyngeal. Sorry, sir.
Well,
Velopharyngeal. Sorry, velopharyngeal needs to be fold needs to be touched with the posterior pharyngeal wall, so it is closed, and thereby creating a complete closed box. And so thereby certain voices, sorry, sir, certain consonants are I mean produced, like the ta, da. These consonants can be produced when the
So there
venopharyngeal
is
closures are.
do you mean to say that there is nasal air escape while we
Yes,
attempt
sir.
to
Yes, sir.
a cleft?
From while phonation, there is escape of air from pharynx to the nasal cavities, sir, through these gaps, sir. And that is why the nasal intonation is taking place. And that is also the reason for nasal regurgitation of any food material the baby is taking. And if the soft palate closure is done at early stage, and then by this stage for this patient, then phonation can also be corrected, and also the regurgitation of the patient, which is the chief complaint for the mother, this can also be corrected, sir.
No, by doing yes, sir. Please.
Yes, sir.
sucking requires closure of this velopharyngeal component.
Yes, sir. Yes, sir.
Because
Yes,
sucking
sir.
requires the creation of a
Negative pressure
inside oral
inside the
cavity.
oral cavity. Yes, sir.
Yes. So solid feeding can be continued without nasal irrigation, but sucking is difficult.
Yes, sir.
Yes, sir. There in Dr. Shubhashish's history, there were two points which I did not find very convincing. Number one is that in presence of feeding difficulties, Shubhashish talked about exclusive breastfeeding for 6 months. In a complete cleft lip, alveolus and palate patient, it is not possible to exclusively breastfeed, and additional feeds or feeds required from time to time to maintain the weight
adequate
and
nutrition of the patient. Yes, sir.
yes, right. So as Professor Shah has told that there is problem of achievement of suction inside the oral cavity while the child latches onto the breast of the mother. So what are the remedies you can suggest when you ask the patient of cleft palate, complete cleft palate, a mother of a child with cleft palate, what are the remedies you can suggest?
Yes, sir. For the feeding advice for the mother, sir.
Yeah, right.
Yes, sir. The feeding advice should be the baby should be fed in an upright position, preferably at 45-degree angle, head placed at 45-degree angle, and specialized uh, uh, feeding bottles with long teats and one valve are available. When placed, these feeding bottles inside the baby's mouth, the baby doesn't need to suck, but the milk gets inside the oral cavity by means of gravitation. And also, the mother is advised for frequent burping for this patient, immediately following the feeding, and also there are certain molding devices to close the gap in the upper palate so as to create an adequate feeding pathway through which the feeding is, the least problematic than the normal stuff.
No, so frequent small meals
Yes, sir.
has to be added. There should be frequent
sir.
small meals.
Small meals, yes. Sir.
So let us go back to your plan. Since you told that you will repair the cleft lip and the soft palate together and the hard palate later. That was your plan, isn't it?
Yes, sir.
Okay.
I'm not sure,
So,
sir, but I think, sir, this may be the plan.
You're not sure. Okay. So at 11 months of age, we have to prioritize our surgery.
Yes, sir.
Obviously, cleft lip leads to certain speech problems if it is present without a cleft palate. So
Yes, sir.
what speech problems, since we are discussing about speech, can be present in a complete cleft lip patient?
Yes, sir. So the voices which
there are some syllables we require
syllables,
bilabial closure.
yes, sir. Yes, sir. Yes, sir. Yes, sir. The consonants which require touching the both lips, like pa, ba. These consonants require touching both the lips, the closure of the lips, and also the ta, da, na. These consonants require touching of the lip to the hard palate, sir. So these consonants. Connection চলে গেছে.
Yeah, hello.
Yeah. You're back.
Yes, sir. Yes, sir. Sir, certain consonants like
Yeah, the
pa,
labial,
ha.
you are talking about the labial consonants, isn't it?
Yeah.
Yes, sir.
In Bengali, since most of our patients speak Bangla,
Yes, sir.
the,
অষ্টবর্ণ যেগুলোকে বলে প ফ ব ভ ম.
that may have problem in a
Yes,
cleft
sir.
lip, complete cleft lip patient. The
Yes,
incomplete
for-
cleft lip patient, however, does not have those problems as they progress, but they do some adjustments in speech.
Yes, sir. Yes, sir. Yes, sir.
And what about the if there is a complete cleft palate?
Yes, sir.
As you told, those are the palatal consonants that has a problem.
Yes, sir.
The only part are the vowels. The vowels like O, A, E.
Yes,
That
sir.
doesn't require active participation of the palate
No,
or the lip
palate.
and can be
Yes.
pronounced. So if
Yes,
you
sir.
want to know the nasal, since the patient is only 11 months age and the mother has noticed that there is nasal intonation of voice, that
Yes, sir.
can be addressed. I think if given a choice, I will like to do the cleft palate surgery, the correction of the complete cleft palate first. And
Okay, sir.
then after 4 months to 5 months, when the child is fit enough and the mother agrees, the parent
Yes,
agrees,
sir.
I will like to do the complete cleft lip repair first.
Lip.
Because when you are repairing the cleft palate, what technique you use to repair the cleft palate?
Sir, there
Can you
are
name some
different.
techniques? Yeah.
Yes, sir. Yes, sir. For cleft lip repair, sir.
Okay, I am talking about cleft palate repair.
Cleft palate repair, sir. Cleft palate repair, sir. WVK, that is Wardell View Kilner repair. Von
Okay.
Langenbeck repair. Farlow's palatoplasty, that is jetplasty technique. This can be done, sir.
So the basic technique what we follow is the VWK.
VWK, yes, sir.
What is the advantage of this technique?
Sir, advantage of this technique is, sir, as the incision line is J-shaped, so the scar line becomes not in a straight line, in a curved line. So there is better
No, you're confusing. You're confusing it with Farlow's Z-plasty or Farlow's double opposing Z-plasty. We are talking about VWK.
VWK. So
view.
lengthening is achieved, sir, in VWK operation, sir.
So
Lengthening
there
of the
is lengthening of the proposed lengthening of the palate.
palate, yes, sir.
Otherwise known
lengthening of
as, what is the other name of VWK repair? Pushback procedure, palatal pushback procedure. So it intends to push back the hard soft palate junction as well as the soft palate towards the pharynx posteriorly.
Oh, okay, sir.
So we can do a VWK repair in this patient, like with a complete cleft of the palate of the right side and achieve
Yes,
the
sir.
palatal closure. But
Yes, sir.
the most, what is responsible for movement of the palate for in a normal palate? What mechanism is responsible for movement of the palate towards the pharynx?
Yes, sir. Sir, there are soft palate consist of certain tensor muscles like tensor veli palatini, palatoglossus, palatopharyngeus, levator palatini. All these muscles contribute to the, the contraction.
The muscles of the palate, they move
Palate,
the
yes,
palate, they move the
towards the
in a
pharynx,
normal
sir.
palate towards the, what happens in an abnormal like this, like a cleft where there is a
Yes,
cleft
sir.
of the palate.
Yes, sir. Sir, as there is discontinuity of the muscle fibers in the midline. So if even the muscles contract, the fold cannot go posteriorly and cannot touch the posterior phalangeal wall, and thereby
So in this
creating
case,
yes,
or in this patient or in this type of patients, there
yes, sir.
is abnormal attachments of the muscles.
Yes, sir.
Especially, what are the, which muscle is the most important? Which muscle do you think among all these, like palatoglossus, palatopharyngeus, like this TVP, like LVP, musculus uvuli, which muscle do you think is the most important for palatal movement? What is the blood supply, nerve supply of this type of muscles?
Sir, these muscles, blood supply, sir, maxillary artery, sir.
A branches from
Branches
the,
of
what is the blood supply of the palate?
the branches of
One vessel come from the foramen.
yes, sir. Sir, branches of maxillary arteries.
Yeah,
There is
so
a branching which needs to be preserved.
yeah, during dissection.
Greater palatine vessels.
Yes, sir.
So greater palatine vessels, which
Greater
are branches
palatine
from the maxillary artery, is
Yes,
the
sir.
principal blood supply. There are other
the palate.
minor blood supplies, especially
Yes,
to
sir.
the soft palate muscles.
Yes, sir.
That you have to know. So the levator veli palatini, LVP, is the sling muscle of the palate. It acts as a
Yes, sir.
sling, roughly a V-shaped sling. It arises from the pterygoid plate and goes and attaches to the other side muscle, forming a V, and lifts the posterior part of the velum, that is the soft palate in majority, towards the
Yes, sir.
pharynx,
Yes,
and achieves a velopharyngeal. What other problems can, apart from speech, apart from feeding problems, what other problems can a cleft palate patient have?
Yes, sir. Sir, there are certain genetic conditions in which the patient can present with.
No, I'm not talking about rare genetic anomalies.
Okay, sir.
I'm talking about
this palate.
This patient.
What are the other functions of palate,
yes,
apart
sir.
from speech and feeding?
Yes, sir. Drainage of nasolacrimal duct, adequate drainage. The muscle lies in close proximity with the nasolacrimal duct. So, in cases of cleft lip, cleft palate, for regurgitation of food material, food particle, and the less competent nasolacrimal, eustachian tube function, sir, not nasolacrimal duct, eustachian tube function, sir. So there is a recurrent incidence of otitis media. And also recurrent ear infection, recurrent chest infection may be present in this patient, sir.
So these muscles, one or two of these muscles, like the levator veli palatini and
Palatini.
tensor veli palatini,
System.
they
Yes, sir.
originate also from the cartilaginous or bony portion of the eustachian tube. And eustachian tube is a
tympanic bone.
connection.
Yes, sir.
What does the eustachian tube connect?
Connect the middle ear cavity with the pharynx, sir. To
Right.
equilibrate, to make equilibrium between the air pressure between these two cavities.
Yeah. So because of inadequate muscle anatomy, pathological anatomy of the muscle, the eustachian tube doesn't open during swallowing. In a normal
Swallowing. Yes, sir.
individual, the
It
eustachian
opens,
tube
sir,
opens
only
during
during swallowing.
swallowing, and that is
Yes, sir.
done by these muscle movements also.
Yes, sir.
So since it doesn't open, there is a tendency of collection in certain patients, not in all patients. There are other mechanisms of eustachian tube function, like
Yes, sir.
yawning and all other. So
Yes,
in
sir.
certain patients, there is collection of middle layer fluid. What type of
Yes, sir.
otitis media is it called?
Otitis
typical-
interna,
It is a serous otitis media.
serous otitis media. Okay, sir.
Yeah,
Okay, sir.
in contrast to a purulent otitis media, which
Yeah, it
happens
is
in
serous.
chronic suppurative otitis media or acute suppurative. It is a so what measures you can take? What preoperative measures if you detect this and the child is not developing speech? Certain patients' mother come and tell that the child is not speaking at all. So
Okay,
not
sir.
speaking at all means there may be problems with hearing.
Hearing also. Yes, sir.
Yeah. So this chronic serous otitis media can lead to what type of deafness?
Conductive hearing deafness, sir.
Yeah, conducting hearing loss or
Hearing
conducting
loss.
hearing deficit. So we can do certain things to maintain an equilibrium of pressure so that the
Yes, sir.
conductive hearing mechanism works well.
Yes, sir.
So what measures? Can you name one or two measures? What is done in a chronic suppurative otitis media?
Yes, sir.
What is the treatment of CSOM?
Yes, sir. Sir, tympanic membrane is
Myringotomy.
myringotomy. Yes, sir. It
Yes.
made a hole is made in the tympanic membrane, and in some cases, certain devices are kept inside so that the drainage is adequate.
Grommet
Right.
insertion.
Grommet insertion.
Yes.
So apart from that, there are problems of dentition, which you have told that there is. What is the commonest problem of cleft palate dentition?
Sir, the first two incisors, sir, the central incisor
Since
and lateral.
speech, I'm interrupting you. Since speech is the part of the palate which is posterior to the hard palate. So
Yes, sir.
in dentition problem, what part of the palate is responsible for dentition?
Sir, primary palate and hard palate, sir.
So what is primary palate?
Primary palate, sir, the part beyond the incisive foramen in front, which consists
Developmentally, from where does it develop? Primary palate.
Yes, sir. Fusion frontonasal process, sir. Medial nasal eminences fuse together. The frontonasal processor come and the forms
What events, and I will what events happen around the stomodium or the
Yes, sir.
primitive oral cavity? That is the stomodium, isn't it?
Yes, sir. Yes, sir.
What events happen?
Sir.
So there is one is
Just
frontonasal.
sound.
Yes, sir. Sir, I'm telling, sir.
Yeah.
Sir, in fourth intrauterine life, there is two bulgings. One is cranial end, one is caudal end. That is head and the cardiac
That is
bulging.
okay.
And
So
in
there is
between
frontonasal process, there is maxillary
Yes, sir.
process, and there is mandibular process.
Mandibular
Now
process. Exactly.
concentrate on the part which gives rise to the maxillary and the frontonasal process. Yeah.
Yes, sir. The frontonasal process come downwards, overriding the somatodium and contributes in the formation of primary
What
palate.
happens? Frontonasal
Yes, sir.
process it is divided
Yes, sir.
by pit.
Yes, sir.
It is demarcated by pit, olfactory pit,
Right.
Yes, sir.
into lateral and medial nasal process.
Yes, sir. And lateral nasal process gives rise to the ala of nose, and two medial nasal processes fuse together in the midline and forms the median bridge of the nose, and the posterior inferior part of frontonasal process gives rise to nasal septum, and anterior inferior part gives rise to the primary palate, sir. Fusion of this
Premaxilla.
premaxilla.
So,
Yes, sir.
so when does the cleft lip happen? Cleft lip
Sir,
can happen rarely
yes.
by non-fusion of the medial nasal processes together, thereby giving rise to actual hair lip or the median cleft lip, which is very
Median
rare.
Yes, sir.
What happens
Sir,
in this? What happened in this patient?
Sir, after the formation, there is fusion between the primary palate and the secondary palate in a Y fashion from
No,
anterior
not
to
about the
posterior.
palate, the lip. Why has the lip
Oh, lip.
clefted?
Failure
Sir,
of?
the upper, yes, sir, yes, sir. The upper lip is formed by contribution from two sources. The middle part, median part, is contributed by the frontonasal process, and the right and left lateral parts are contributed by the maxillary process, sir.
Right.
And yes, sir, if this fusion between these two components,
Which two components?
maxillary and frontonasal components, if there
Which
is a
yeah, okay, I understand. Okay, you are correct, but you should be more specific. No problem.
Yes,
There is failure of apoptosis. There is pre-programmed apoptosis, and there
yes,
is
sir.
non-fusion of the medial nasal process with the maxillary process.
Maxillary process, yes, sir.
How does the palate develop?
So palate is divided into primarily divided into two parts: primary palate, secondary palate. The primary palate developments are already been discussed. Now the secondary palate is contributed on the heart palate. So there is a two palatine shapes from both sides of the maxillary processes, which initially remain in vertical position, and in between these two positions, the tongue develops, and later when the tongue descends, making room for the two vertical palatine processes to become horizontal and fuse together in the midline. And fusion takes place from incisive foramen from anterior to posterior. But the soft palate is developed from the muscles, sorry, sir, mesoderm, sir, mesodermal origin.
From
Seven,
where?
sir, I forgot, sir.
Okay.
Sorry, sir. Soft palate.
So all muscles of that is why I was asking the question, what is the nerve supply
Yes,
of
sir.
the palatal?
Sorry, sir. First arch. It is contributed from first arch, sir.
So in what we were discussing is about the dentition. So the problems, the tooth buds
Yes, sir.
are present inside the alveolar processes.
Alveolar processes. Yes, sir.
Since there is a cleft of the alveolus on one side,
Yes,
there
sir.
is malalignment of teeth, as you have mentioned, which
Yes,
may
sir.
lead to later further difficulty in feeding, and also
Yes,
there are certain part of the speech which we produce by using the tooth, the
yes, sir.
teeth, the
Yes,
tongue
sir.
hitting the teeth.
Yes, sir.
So that part will have problems. So the commonest tooth which usually has a problem is the upper
lateral incisor.
incisor.
Yes,
And you also spoke about certain orthodontic or orthopedic measures being taken. Can
yes,
you
sir.
throw some light on what we can do pre-operatively?
Yes, sir.
Which is usually done in cases of complete bilateral cleft of the lip and the alveolus.
Sir, bone graft is taken from ILF paste
No,
and is
not graft,
implanted.
not graft.
No,
Pre-op.
not graft.
Not graft,
Pre-operative.
pre-op. Some orthodontic appliances may help the child to take feeds, can prevent this
Yes, sir.
recalcitrant infection.
Nasoalveolar molding, sir. Nasoalveolar molding. Yes, sir. Can be placed in the gap in the hard palate, thereby creating a complete roof of the oral cavity.
So before the child attains an age of 6 months,
Yes, sir.
these measures, certain measures can be adopted to mold the nose, the cleft of the
Yeah,
nose,
yes, sir.
which is
Yes, sir.
the cleft of the palate,
Yes, sir.
and the cleft of the alveolus. So
Yes, sir.
that is summarily is called the nasoalveolar molding. But initially for palatal expansion,
Yes, sir.
and the certain palates which are high arch palate can
Yes,
be brought to a level, and
Yes, sir.
and the protruding prolabium. The prolabium
Protruding
is the part
prolabium.
of
Yes,
the
sir.
primary palate,
Central part. Yes, sir.
which is completely lying free and only attached to the nasal septum in cases of
Yes, sir.
complete cleft lip, in
Yes, sir.
cases of complete bilateral cleft lip and palate. So
Yes.
the protruding prolabium, which occurs due to the unrestricted growth of the nasal septum in the midline, that
Yes, sir.
can be corrected by certain measures known as
Yes, sir.
orthopedic measures. Why orthopedic? Because these are not orthodontic, because there are certain terminologies like before 6 months, the bones are soft and
Yes, sir.
bones can be manipulated. Bones
Yes,
can
sir.
be manipulated because of high maternal estrogen. So
Yes,
that
sir.
you can modify or you can mold the palate. So before
sir.
6 months of age, this is possible, and certain preoperative measures to bring the palatal cleft, since your gap
sir.
was 1 centimeter, which is quite big. 1
Yes, sir.
centimeter gap is quite big. You may need
Yes.
additional tissues from the cheeks
Yes, sir.
or from the tongue to fill the defect if there is, and there is high chance of failure. To
Yes,
decrease
sir.
this high chance of failure of the palatal repair, we can
Yes, sir.
do the palatal expansion procedure, where the palatal length, the gap is reduced and prolabium is brought to the brought to less protruding position.
Okay, sir.
So what anesthesia you will give in this, planning to give in the planning for this patient?
General anesthesia, sir.
So in cleft lip repair,
Yes, sir.
or in your first procedure, what special general anesthesia measures you want to adopt, or you will ask the anesthesiologist colleague to adopt, or what do we do in cleft palate or cleft lip surgeries? Where is the tube placed? In a normal general anesthesia procedure?
Orotracheal or nasotracheal?
Normally, sir, so orotracheal is done, but in this case, since the site of surgery is oral cavities, or nasotracheal might be
No,
preferred, sir.
nasotracheal is not necessary in these cases. Orotracheal intubation may be done,
Yes,
but
sir.
I am talking about the position of the tube.
Okay, sir.
Where will you like to place the tube position while you are repairing the cleft lip?
Sorry, sir, I don't know, sir.
It should be placed in the lower lip, in the center
sir.
of the
Okay,
lower
sir.
lip.
Okay, sir.
And in cases of repair of the cleft palate, it should be a non-collapsible tube. There is a special name of the tube
Yes, sir. Yes,
used.
sir.
What can you
Malleable.
name it?
Mhm.
The shape of the tube is also little characteristic.
Fantastic. Yes, sir.
It has an acute
Okay.
curvature, and
Right angle tube, sir. Right angle tube. 90-degree angle it
it
has.
is called RAE tube.
RE. Yes, sir.
Yeah, and it doesn't allow the collapse in spite of the bend.
Yes, sir.
So what methods are there for cleft lip repair?
Yes, sir. For cleft lip repair, sir, there are Millard repair technique and Tennyson jet plasty, sir. These two techniques I know, sir.
Yeah. So Millard rotation advancement technique.
Yes, sir.
So and what is the other technique you have told?
Tennyson jet plasty.
Can you spell the what you are telling? Can you spell it?
TENNINSON Tennyson Z plastic. PLASTY, sir.
Yeah, right. Tennyson.
Tennyson. Yes, sir.
Yeah. Tennyson's straight line repair with a Z-plasty.
Yes, sir.
And more commonly, what is practiced is Millard's rotation
Millard.
advancement
sir.
advancement lip repair, where
Yes.
we rotate the non-affected side,
Yes, sir.
that is the medial segment, and we
Yes, sir.
advance the lateral segment.
Yes, sir.
So what do we correct in cleft lip? What is the difference we correct? What difference do we measure?
Sir, the difference we measure the in the normal side, that is the inside. So the length between the peak of the cupid's bow and the
Okay.
base of the lateral edge of the base of the columella is measured, sir, on
So
the
this
inside.
is otherwise known as the lip height.
Yes, sir. Lip height.
We intend to correct the lip height because
Yes, sir.
in a cleft lip patients,
Yes, sir.
can you describe what are the problems if there is an isolated cleft lip,
Yes, sir.
cleft of the lip?
Yes, sir. Sir, there may be, as there is a opening in the oral
So
cavity.
normal
sir.
lip is horizontal.
Yes, sir.
What is the cleft lip patient? How is the lip? Is it horizontal?
No, sir. In V-shaped or
Yeah, it is oblique. It is oblique.
oblique, sir. Yes, sir.
So what about the what is Cupid's bow?
Cupid's bow is formed. The base is formed by the. A Cupid's bow is a U-shaped bow-like imaginary bow, which is the two points at the.
Okay. So
sir,
Cupid's bow is a feature of the white roll. The white roll.
Yes, sir. Yes, sir.
The
Yes, sir.
white roll
roll.
is present in between the junction of the normal skin, that is the
Normal
labial
skin and the labial
and the
skin.
dry vermilion. So vermilion
Yes, sir.
has upper
Yes, sir.
two portions, the wet and the dry. So
Yes, sir.
white roll, a Cupid's bow is a feature on the white roll. And
Yes, sir.
on the normal side, the unaffected side Cupid's bow and the affected side Cupid's bow is not present at the same horizontal level. And by the
Yes, sir.
surgery, we
Yes, sir.
intend to make it in
In
the
a same
same
level.
horizontal level. We
Yes,
intend
sir.
to correct the lip height. What are
Affected
the
level-
lip muscles? Since
Sir,
you have told about palatal muscles, what are the lip
Yes, sir.
muscles?
Lip muscles are orbicularis oris, which has got a vertical and horizontal part.
Yes.
There are some lip
Yeah.
muscles which are nasolabial, bilabial.
ওটা স্যার নোজের কাছে ছিল ট্রান্সলেজাল টেন্সর
So there are certain lip elevators, lip depressors, as well
yes
as
sir yes sir
the orbicularis. What is the nerve supply of orbicularis oris?
These are all facial muscles supplied by
facial nerve sir which
Facial nerve.
mandibular branch
no, facial.
facial nerve sir yes sir.
So there is abnormal attachment in cases of complete cleft of the lip. There is abnormal attachment of the orbicularis oris
Yes sir.
Around the cleft margins. So ideally it should be like a sphincter. Orbicularis oris is like a sphincter.
Sphincter, yes sir.
Thereby giving rise to major part of the oral sphincter.
Yes sir.
Thereby leading to adequate lip closure and also,
opening, yes sir.
And opening and good feeding also. It
Yes,
helps
sir.
in feeding. But here orbicularis oris has abnormal attachments to the margins of the cleft in the alveolus.
Yes sir.
And so in your repair, you should tell that I will do a Millard rotation advancement repair and also correct the muscular diastasis or muscular, I will intend to correct the pathological anatomy of the orbicularis oris.
Okay sir.
So it is repaired in 3 layers, like the
Yes,
skin, the muscle,
Yes, sir.
and the mucosa.
Muscle and mucosa. Yes sir.
Palate, how many layers it is repaired?
Mucosa and muscles and
Yes.
mucosa and muscle.
You
Yes, sir.
say what?
Mucosa and muscles, sir.
Muscle
Also,
where? In the hard palate there is muscles.
no, so in soft palate, sir.
Yes, so it is also repaired in roughly 3 layers. There is one palatal mucosa or
Yes, sir.
palatal fibromucosa. In middle
Yes,
part
sir.
there is middle and posterior part there is muscle, and
Yes,
the
sir.
lower part there is nasal mucosa.
Nasal mucosa. Okay, sir.
The nasal mucosa is different than oral or palatal mucosa.
Yes, sir.
Sir, I think Dr. Subhash is a
Yes, yes. For MA student, basic part is covered. You see, the first thing is
Yes,
to
sir.
good description of the patient and excluding other congenital anomalies. You should specifically what the anomalies you have searched in this patient. Patient having a cleft lip and palate. What other
Yes,
important
yes, sir.
congenital anomaly you have searched?
Yes, sir. Sir, the Pierre-Robin sequence, Strickler syndrome, Springen syndrome, down apart,
What other?
Dieter syndrome.
Name some congenital anomalies which may be associated. You have examined in this patient.
Down syndrome, apart syndrome, Teacher-Collin syndrome, sir.
I'm not asking syndrome. I am asking. Suppose you are examining the patient, na? You have examined
Yes,
What
this
sir.
are the
patient.
common congenital anomalies associated with cleft? Sir is asking them.
Other congenital anomalies. There may be,
Yes.
sir, cardiac anomalies. So there may be ophthalmic problems.
You say
Cardiac
called as a
problems.
vertebral anomalies. You should look for vertebral anomalies.
Vertebral. Okay.
Patient may have hemivertebra, bending of vertebral body. Okay.
Yes, sir.
Then
Yes, sir.
patient may have anal anomalies. In a male
Yes,
patient,
sir.
you have undescended testis. Or
Yes, sir.
patient
Yes,
have
sir. Anorectal
hypospadias.
malformation. Yes,
So
sir. Yes, sir.
what I'm saying is you are not looking for syndrome. You are
Yes,
looking
sir. Yes,
for
sir.
other important
Problem.
congenital in the
Other
particular
problems.
patient.
Sorry, sir.
Okay.
Yes, sir. Yes, sir.
Because I noticed one time you said that this patient has recurrent cough, so I'll do echocardiography. Recurrent cough is because of cardiac anomalies, or it can be because just of the cleft and the palate itself.
So both can be the possibility, sir.
Yes.
Sir,
A patient having a complete cleft palate may have recurrent
Yes,
chest infection.
yes, sir. This is very common, sir. Yes, sir.
Yeah. I think we have covered this part.
Yes,
You see,
sir.
basically, you should know the developmental process of the lip and the palate.
Very
You should be
important.
knowing the anatomy, the different muscles in the lip, muscles in the palate, their nerve supply, and principles of repair and the timing. You see, there are different timing being given, but most of the cases, if it's isolated lip, cleft lip, you can repair as early as 3 months. Okay,
Yes, sir.
but
Yes, sir.
ideally, the baby should be fit. Hemoglobin should be 10. At least
Yes.
the baby should be 10 kg weight. So there are some norms for taking up this patient for surgery. Dr.
Yes,
Das, I
sir.
think we have covered the almost the whole
Yes, sir.
part of this.
Yes, sir.
Thank you
Yes,
very
sir.
much. Any question
Thank
from anyone?
Sir,
Anyone
I
who
have a
can-
question. Sir, that's
Yes,
sir.
yes, yes.
Sir, I couldn't understand one point while studying the Nordhofen point. Everyone is saying that is debatable point. Where the point is located, I couldn't appreciate, sir.
Nudov's point. Are you talking about
Yes, sir.
Nudov's point?
Nordhofen point, sir. Yes, sir.
Yeah. It is a imaginary point.
Yes, sir.
It is used during the surgery of the cleft lip.
Yes, sir.
So the white roll in the cleft lip patient
Yes, sir.
on the affected side. Suppose your patient, can you you have to get back to your slides.
Okay.
So there is a point where if you trace the white roll from
Yes, sir.
the angle of the mouth towards
Yes,
the
sir.
cleft, okay,
Yes, sir.
towards the cleft, from angle of mouth, you are
Angle of
tracing
mouth
the white
towards
roll
the cleft.
towards
Yes,
the
sir.
cleft.
Yes, sir.
On the affected side, okay.
Yes, sir. On the affected side. Yes, sir.
Not
L
on
side.
the unaffected side, on the affected
Yes, sir.
side. So
Affected side.
on the unaffected side, you will find firstly the highest point of the Cupid's bow.
Yes, sir. Highest
You
point.
will find
Yes,
the
sir.
highest point of the Cupid's bow. See
Yes,
here,
sir.
the affected side is the right side, okay,
Yes, sir.
in right side of the patient,
Yes,
and
sir.
the unaffected side of the cleft lip is the left side.
Yes,
So
sir.
if you are tracing the white roll, that is
Yes,
the
sir.
mucocutaneous junction
Junction. Yes, sir.
from the angle of the mouth towards the
Hmm.
cleft.
Yes, sir.
At one point, there will be the white roll will fade away.
Okay, sir.
That is, the white roll will start fading. Okay,
Okay, sir.
that is at up till a point there will be good white roll. You can if you intently see, there will be good white roll, and after that,
Yes, sir.
that white roll, that raised
Yes.
shoulder, yeah, I can tell the raised shoulder, that
Yes, sir.
will gradually fade. That point is called the Nudov's point. It
Nodose
will
point.
also
Okay.
correspond to the widest vermilion. Widest vermilion,
Whitish
that is the
vermilion.
red vermilion,
Whitish
yes.
vermilion. Okay, sir.
Widest vermilion, and that point is marked as the base of the advancement flap.
Right. Yes, sir.
Okay, so it
Okay.
it has got significance. We can sometimes measure height of the affected side taking into the length of the lip. That is, if you measure the angle of the lip to
Yes,
the
sir.
Nudov's point
Yes, sir.
on the affected side, it should correspond to the same angle of the lip on
Yes,
the
sir.
unaffected side to the highest point of the Cupid's bow.
Yeah, it's one. Because the corrected portion will be equal to the non-corrected
Yes.
normal portion. Yes, sir. Okay, got it. Thank you, sir.
Thank you. Thank you, sir.
Thank you. Thank you very much. Thank you.